Jeff, that was quite a sigh.
I'm tired.
Yeah, so am I. I spent the morning working at a food pantry, boxing food.
Is there enough to box?
There is. It was wonderful over the last year as the Oregon Food Bank got out of the business of going and picking up food that's about to expire from local stores. The pantries are now doing it. So we get food from Whole Foods and Trader Joe's and Fred Meyer, and I think they're now getting things organized with the local Albertsons, and we get high quality food. It's and then we still get stuff from the food bank where they have the surplus, and they bring out boxes of apples and potatoes and things like that.
I've done some volunteering at a camp out past Yamhill, and they get a lot of food from Trader Joe's.
Yeah. I
makes you wonder how much they're not selling there.
Well, my guess is that it's a 10%, 5 to 10% of the stuff that they bring in, they pass on, and the fact that it doesn't get just thrown away is the key.
That's great.
Yeah.
Well, have we got all of our sound kind of cleared up?
Yeah, I think so. We're going to give it a go. I think we're in good shape, and I'm just looking at who's here so far. We'll give it just a few more.
People are signing in, yeah.
Yeah, people are still arriving.
JS or JJS?
Idaho, I'm here.
We're missing the other board. Where are we?
I am just looking. Yeah, it doesn't look like Sean has arrived yet. And I am not sure. Ollie, did you know, was Kimberly planning to attend today?
I didn't hear from Kimberly, but I'm sure Sean is.
Yeah. We just had a pretty detailed and interesting PEP board meeting, so he's probably just trying to finish up a little break in between.
That's right. I keep forgetting about that.
That'd be rough having that board, and then that's a lot for the brain to take.
It's a long day.
Yeah.
Well, it's kind of like the OA board meeting day.
Yeah, exactly. It's exactly the same.
What I miss is going for a walk around the block with Tom at lunch when it's sunny.
Where we can solve the world's problems.
Yep. 1 foot after
or not. Or not.
Ah, there he is.
Yeah.
That's a festive shirt.
You got to keep it festive these days, you know?
Aloha.
Okay.
And there she is. Now we can start.
Great.
Right, Margaret?
I think so.
I have your permission? Okay.
You do. You do.
Okay. Well, I'm going to call together the March 16th meeting of the Innovation Work Group. And the first order of business, as always, is to obtain approval of the last meeting synopsis. Everybody had a chance to look at it? And
Mr. JJ, I move to approve.
Okay. Is there a second?
Second.
Okay. All in favor?
Aye.
Aye.
Aye. Maybe we ought to do the hand thing, but we'll move forward. Nobody's against, right? Okay.
Jeff, this is Tom.
Yeah.
I forget. Am I a voting member or not? A non-vote. I think I'm a non-voting. Okay, fine. I will not raise my hand. And now I will mute.
Okay, so we'll move on to legislative update, and Ali and Glenn.
I think it's all Glenn. Go ahead, Glenn.
Looking for him.
If Glenn's on. Well, I can fill in.
Or, well, ooh.
Yeah, I'm not seeing him on the side.
Another option is if we have the full Mercer team here ready to go, we can come back to the legislative update later if that's easier.
Let's do that.
Great.
Do we have the full Mercer team here?
I think we do.
Show yourself.
James is here. I think I saw Michael on. What's the next agenda topic, Margaret?
It would be moving right to the performance guarantees presentation.
Okay.
Yep, I'm here.
Yep, there's Michael.
Okay.
Great. So I just learned how to do that with PDFs. I did not know you could do that. You know, with PowerPoint, you can go to the next slide. The first few slides are basically a review from last month, just to remind everybody of the framework. So you can kind of go through those. Whoever, are you driving it, Margaret?
I am driving the slide deck today, Michael. Yes. So
That's
feel
great.
free to just give me prompts.
Yep. So we're going to just do a little background, and then we're going to get into the PG comparison recommendations, and then there's a bunch of material in the appendix, which we likely will not get to. Go ahead. Next slide. Next slide. So here's where I identify the goals of performance guarantees. As we talk about this, I just want to make sure that we remember this is about being good stewards, optimizing the member experience, supporting evidence-based quality clinical guidelines, and ensuring that your benefit partners meet all of the obligations in administering the best-in-class health plan. Next slide. So it's not just about healthcare delivery, but also health plan administration. So here are the guiding principles, which I asked a couple of you last time, and there was indication that this aligned with what people thought should be the guiding principles. So you can read them yourself, but I just want to remind everybody that we had identified these last month. So we want to make them, meaningful, not administratively burdensome, and appropriate for your population. Go to the next slide. And some more guiding principles for benchmarks and goals. So national benchmarks or best in class, if that's available. You can, the benchmarks can be modified over time. You don't have to stay at that level forever and ever. You can retire metrics if they're no longer applicable, or if the benefit partners are consistently meeting the benchmarks. And also you can increase the amount of PGs at risk over time. And make adjustments based on performance. And I think there was a lot of discussion last time around that. For example, if a benefit partner appears to be doing really well, maybe back off on the PGs if there appear to be issues potentially increasing, but making adjustments certainly is acceptable, in fact indicated. On the next slide.
Michael, this is Jeff.
Yeah.
One thing since our last discussion that's kind of come to my consciousness is we need to remember that performance guarantees we make are often involve a subgroup, meaning the physicians, the providers. So we need to make sure that we're able to negotiate those, obtain the data, and we don't change it very often because that becomes complicated.
With the with the clinical quality measures, that's true.
Yeah, that's what I'm
and
getting at.
yeah. And I think there's a bullet marker a couple ones back. If you could, we captured that. I thought. Balanced reporting of actionable outcome-focused measures and administrative burden. So Jeff, to your point, one of the things that I hear from health systems is that there's administrative burden on the number of quality metrics they have to report out for Medicare, Medicaid, and private sector health plans. So that's absolutely, that's how we captured that. And it's for physicians, hospitals, whomever.
Exactly.
Yep, absolutely. Yep. Okay, but I also just point out that we're also looking at metrics at the health plan level and not necessarily the provider level, which is a concept that we introduced. So we identified these 6 categories of performance guarantees last time, and we just gave you examples. And we were charged this time with providing recommendations in each one of these categories. So that's what we're going to do. We'll walk through those with you. Next slide. So first, we wanted to show you this comparison. This shows the PEB plans, the OEB plan, and we had 2 examples. One was from the state of Alaska for their employee benefit plan, and the Washington State Healthcare Authority for these are state employee benefit programs. And we'll show in more detail where they're at with each one of the categories. Mercer best practices is about 20%. Of fees at risk. I've seen them routinely be 25%, but we're saying best practice is 20%. And you can see where the other plans line up in terms of where they're at. So there's definitely room for improvement in terms of putting fees at risk. I think we had a general discussion that we wanted to align both PEB and OEB probably to where OEB is at, around 15%. Which was kind of our marching orders from last time. I also just want to say the reason I said at the very beginning that we can revisit this every year, so we wouldn't want to jump from 4, 5, 4, 6, 7% for PEB to 20% overnight. And we wanted to do this thoughtfully. We want to make it meaningful and relevant, not administratively burdensome, to Jeff's point. So we just thought it would be helpful to see where your plans are out versus a couple of other plans and where Mercer sees as best practice.
This is Tom, a quick question. I just wanted to make sure when you say percent of fees at risk, you're not talking about claims, you're talking about just the administrative fee.
Right,
for
the self-funded plans, yes.
Yeah.
Kaiser is just different because it's fully insured.
Right. And OEB, where MODA is fully insured also, but they have there is a claims component and there's an administrative fee component.
Yes, that's what it's about. Yeah.
Okay. Thank you.
Yep. So I don't know whether any of my Mercer colleagues want to chime in, or if other people have input on this slide. Any other questions? Okay, go to the next slide. So this one's a little bit hard to read, and I might ask, Mitch, are you on the line? You want to explain this one? This gets a little tricky. Nope, he's not on the line. All right, I will try to explain this. So we were trying to give you the ASO fee benchmarking comparison between your plans and what we find from our own database, from Mercer's database on the ASO fee benchmarking. And you can see where MODA is, the choice plan, the statewide plan, those are PEB, and OEB plans in terms of where your fees are. Now, having said that, the coordinated care model plans do require additional staffing services, intensity of services, and so forth than a PPO plan. So I just wanted to point that out to you as well. So the first comparison is plans that are most similar to PEB. We also show that competitive marketing tends to result in lower fees, 10 to 15% on average. So in other words, when a plan goes out to market, you typically see fees going down. And also increases in member counts will increase administrative fees, 1 to 5% on average. So there is some fluctuation in the fees. We've shown this in similar format to the PEB board, but the OEB board may not have seen this before. So it is higher than what we see in other plans, but again, the coordinated care models are different in terms of what they're attempting to do through clinical management programs. But you'll see that one of the newer categories that we're suggesting is what we call clinical management. So that's like utilization management, case management, disease management, to have some fees at risk around the clinical management programs because they're supposed to be more enhanced as a result of the coordinated care model. And yeah, I'll just leave it at that. Any questions here? No. Okay, on the next slide. This is not really a PG thing, but I thought we would mention that. So administrative and operational. So with each one of these, we want to explain what we mean by this and, excuse me, fees at risk. So this includes the core plan administration and operation. This is claims administration, member services or call center. So things like average speed to answer. We'll show you some of the examples of metrics that you currently have, some that we're recommending and some that we're actually recommending that you retire. So you can see here where the PEB plans are in terms of administrative and operational metrics, where the state of Alaska, which is in pink, and the Washington State Healthcare Authority, which is to the far right in blue. So you can see Kaiser has the 7% of fees at risk, Providence Health Plan 4%, and MODA at 6%. MODA, that is for PEB, by the way. And then the OEB fees at risk, 2.25%. So I do want to point out that Providence does have their triple aim incentive, which is a bit complicated. I just want to make sure that we say that because I'm sure that our Providence colleagues are on the line. Those are overall for lower cost, member experience, improved quality. But these are really talking about the core health plan administrative and operational functions for these different plans. Do you have any? Okay, here we go. No, that's all right. You can go to the next one. So here are the recommended metrics, and you can see the first few there are already in the plans. You can see PEB and OEB have those. We're recommending 3 new ones, and we're recommending several to be deleted. So we're not just just adding more metrics. And then we're also recommending benchmarks for the different metrics there you can see. And the 3 that we're adding, email response time, because what we find with call centers or contact centers is more and more people are doing emailing and not phone calling. And so we want to have a measure that is related to emails and not just phone calls. Telephone inquiry response time within either 10 days or 28 days. Excuse me, the email response is 24 hours versus 4 days. And then procedural accuracy. So that making sure that the procedures that are coded are accurate. You could also see where we've indicated that some of these metrics could be verified by a claims audit. They could be self-report, but it also could be where you have a claims audit that goes in and verifies what we're seeing in terms of accuracy, turnaround time, et cetera, through a sampling of claims or appeals, turnaround time, and so forth. So it's a little confusing. Like, let's say you look at the appeals within 30 days or 72 hours, or excuse me, let me see. Email response time, 24 hours or 4 days. You can see 85% within 24 hours, 95% within 4 days. That's what that slash means between the two. You go to the next slide. So we're suggesting add 3, and we're suggesting that those 8 metrics be deleted. PEB currently has them. OEB has 2 of them. We just think that this may be holdover from another time where there may have been an issue. And these are not common metrics that I see very often. Plus, I think we want to focus on the most important metrics that are relevant to your member population. Any questions or? Nope. Okay.
This is Tom. I was a little surprised to see the mail order pharmacy turned around within 5 days. That seems to be an important one. It's a clinical one, and again, it's health plans aren't dispensing drugs, pharmacies are. So I don't know how you test that one, but I don't want to derail the conversation, but it was one that I thought, I think it's an important one if it actually means a member submits a prescription to a mail order pharmacy, and the assumption is that it's sent out within 5 days. I assumed that that's what it meant.
Yeah, right. And that could be, again, self-report. It also could be verified at claims audit. If you want to fold back in some of these, we can certainly do that, or we can make them report only. We were tasked with trying to make the, not be too burdensome with all the metrics.
Yeah, I understand.
Yeah, it's not to say that's not important. It's just I don't see that as a common metric.
May not be an issue. So that's fine.
Yeah. And it could be something where you measure this when you do a claims audit of your PBM, and you definitely would want to look at it then. Did I interrupt somebody?
Hi, Michael, it's Ruby. This is Ruby Casnetta, and I'm with PEB and OWEB, one of the staff people. And I just wanted it to, I worked with Michael, and these are also some things that I have seen in doing administrative and operational metrics for other plants where I have come from before in the past. And some of these weren't really typical in the industry that I have seen either. So I just wanted to reiterate that Mercer and staff did review some of this information prior to presenting to IWG.
Thanks, Ruby. And again, things like grievances, mail order turnaround time, mail order accuracy could all be things that you pick up during an audit, and should be, actually. Okay, go to the next slide. So that's administrative and operational metrics. Financial trend PGs, you can see that none of the PEB or OWEB have financial trend PGs in place. Neither does Alaska state employees, and Healthcare Authority does. Again, I want to just give a call out to Providence that they do have financial guarantees related to the triple aim, but there are some requirements around receiving the triple aim. And I think we can go to the next one, and I might have James have you talk about this one, if you're still there.
Yes, I am.
Since you're an actuary and I am not.
Yes. Give me just a minute to warm up here. My camera working, my microphone working.
Mm-hmm.
Michael, I'm not totally prepared on this one, so give me just a second. Give me just a second. This is where we wanted to have a financial trend guarantee. I think we heard some of this from Sean and maybe from Jeff. And so the suggestion is that we would have a 3.4% trend target because, well, we have a 3.4% trend target. And then we thought that a reasonable approach would be for every 1% that you don't make 3.4. So if you're at 4.4, 2% of admin fees would be the penalty. And 5.4 would be 4%, but 6.4 would not be 6%. There would be a maximum of 5%. So something the boards will want to consider is how to allocate the financial impact across the different metric families. So this is just a first suggestion to try and put some teeth in the trend guarantee. The percents apply to admin fees, of course, not claims, whereas trend applies to claims. So the penalties are not at the same scale of claims dollars, but these would be noticeable and probably provide quite a strong incentive to control cost.
James, Jeff, are you talking cost of claims or claim amounts?
For the definition of what's in the 3.4% trend?
Yeah.
Whatever we're using to validate the 3.4% trend. So I think there might be some room to finalize that definition, Jeff, but the same 3.4% trend that we live with, we would then parse to the plans.
And this is Tom. So when you have a year like we just went through, trend will be, let's guess, minus 8%. And next year, when it just goes back to normal, it will go up 11% because of those changes. So how do we deal with that?
Margaret, help me with which years the performance guarantees are waived.
Well, so in our contracts, we have waived guarantees for plan year for 2020 and 2021 calendar
Good.
years
Okay.
due to
Answers
the pandemic.
my question.
Okay.
Yeah.
So yeah. So stepping back, everything we're proposing here would take effect with the next plan year. So October 1 of 21 for OEB and January 1 of 22 for PEB.
Okay.
And where we are talking about measurement years generally, like for example, clinical quality, your measurement year is typically based on a calendar year. It would be the 2022 measurement year.
Right.
And this is Ollie. I would just mention there's two 3.4% tests in statute. Well, the first one is the premiums that the board adopts on a composite rate level, and then second one is a look back. It's the actual cost for that given plan year per employee per month. So you'd want to be specific about which one, if not both. For OEB, they're pretty much one and the same, passing the premiums through. For PEB, it's obviously, with being self-insured, it's variable and can be quite different.
So I know Emery's on the call, and it might be that this is a level of detail that we would save for the actual sausage making, but Emery, did you want to make a comment?
Actually, not really. I mean, as James mentioned, if we want to get more into the details, I'm not sure it's necessary for the purposes of this meeting, but we can clarify that for a follow-up meeting or with staff.
And have we gotten
an agreement?
Yeah, have we gotten any feedback yet from the 3 health plans?
That's the next step, Tom. This is Michael.
Cool.
We wanted to show this to you first.
Yeah,
because you said no, we don't want this. Then the next step would be, and you're jumping ahead to our next slide.
Sorry.
No, that's okay. That's exactly what we want to do. Yep.
Okay.
The next slide. Clinical quality APGs. Margaret's going to talk about this one. I would just make a comment though, Tom, since you asked the question. Many of these metrics are probably or likely already included, particularly for their other self-funded plans, maybe not for fully insured, but self-funded plans. So your plan should be pretty used to these. The 2 new categories would be the financial trend, which James just talked about, and the transparency metrics, which we'll talk about a little bit. Those will be new, likely to be new, but the administrative and operational, the clinical quality, account management, those should not be new to any of your carrier or administrators. So Margaret, you wanted to do this one?
Yeah, absolutely. Thanks, Michael. Yeah, so I'll walk through the clinical quality performance guarantee, sort of what we're proposing at this initial level. And again, just to kind of give a little bit more context to what Michael explained, what we're really looking for today is input and conceptual agreement or consensus from the work group. We want your input on which categories of measures are most meaningful. We'll talk a little bit as we get further into the presentation about the level of fees at risk we're proposing. And we'll want your input on how to allocate those fees at risk across the different categories. We have recommendations, but we want to hear your discussion on those recommendations and input. Our next step after this then will be to refine this and then seek the carrier input that Tom asked about, so that we're capturing that input and having that dialogue before we come back to the innovation work group with kind of what we have mapped out as the final approach based on all of the input and conversation. So again, kind of just at a conceptual level, PEB and OEB contracts have both contained clinical quality metrics for a number of years now. And as this work group is well aware, we do base the metrics that we incentivize on in contract. We base them on the state's aligned measures menu that's developed by the Health Plan Quality Metrics Committee. By statute, we have to select measures from that menu. We also work we work in coordination with our OHA colleagues in health analytics on the CCO metric side to sort of coordinate. And so we don't have necessarily 100% of alignment across metrics because of the different populations covered. Some metrics make more sense for a commercial plan as opposed to the coordinated care organizations and vice versa. But we do coordinate to try to generally align as much as possible. And this slide just sort of demonstrates kind of where we're at currently with fees at risk on our clinical quality measures. And yeah, I mean, I think this is pretty straightforward. Moving forward, what we're proposing for, and again, this would be for measurement year 2022, so for upcoming contracts, we are proposing adding some new measures. You can see at the bottom of the screen, we have in that bolded box, new measures we are proposing adding to our clinical quality metrics collection. In particular, they are largely related to including more measures that get at member experience. These specifically come from the CAP survey. And then in addition, I think for benchmarking is another approach to this that we want to take a look at and refine. So historically, across all of our plans, with the exception of Kaiser, we have used the HEDIS national PPO percentiles as the benchmark for all plans. For Kaiser, we have used the HMO percentiles. For 2022, we would like to move forward with an approach that uses a different, generally higher benchmark for coordinated care model plans than the PPO benchmark. So that rather than using that PPO benchmark, we would retain that for PPO plans, but for the coordinated care model plans, we would use the PPO HMO combined percentile, which sets generally higher expectation of performance for those coordinated care models. And I don't want to get too hung up. There's a box in the corner that talks about scoring and how we would consider plans met and not met. And I don't want to get too hung up on that right now because I think that actually, candidly needs more detail to be worked out. But we've generally set the target at, our benchmark at the 75th percentile, and plans either meet it or not. And I think we would like to move to an approach where we do provide some additional incentive for plans to go above and beyond the 75th percentile, so that if they hit the 75th percentile and meet that benchmark, they would get a certain point allocation. But if they hit a higher threshold, they would have the opportunity to earn additional points. And I think this is important because while we do want to recognize that the 75th percentile is a commendable level of performance, we want to continue to incentivize or encourage carriers to exceed that and to continue to improve performance. So I think when we look at our scoring framework, that's something that we definitely want to build in. Now, this total list has a total of 16 metrics, and I think some folks would look at that and say that's potentially too many. I mean, I think there's varying opinions on, whether it's a dozen or 20 or somewhere in between. I think we feel like this is a good kind of middle ground in terms of covering a number of different areas of care. And also, when you look at the scoring, I think, having a robust collection of measures provides the plans with opportunity to improve scoring in certain areas. I think one question that comes out of this is always, well, can you miss any measures, and how many can you miss? And I think certainly when you include more measures, not that you want to be focusing on too broad of an array of measures, but when you include more, it is, you do have more flexibility in terms of how you structure the scoring. So this list of 16 is what we're proposing for the 2022 plan year.
So I'll get kind of an odd question. If you go back a page, we've been using Alaska and Washington as comparators. Clinical is probably the most important group that we want to compare, and Alaska doesn't have any. So why are we using Alaska as one of our comparators?
Because it's what we had available, Jeff. I also would say that you're ahead of the game in terms of clinical quality PGs. I don't routinely see these. So I would say both OEV and PEB are ahead of the game in terms of having clinical quality metrics included.
This is I'm sorry, Jeff, right? Are you finished?
Well, I was just going to say, does Massachusetts have them? Does, Rhode Island, some of the other states on the East Coast? And Tom, you may know the answer.
I don't know the answer to that. The question that I had to do with the 3 of the metrics that were in the CAP survey.
Okay.
So I don't know the answer to that, Jeff. These are the RFPs that we had readily available. We would need to do a Freedom of Information Act request to get a sampling of other state employee benefit plans, which will take a while to get that, but we could.
I'm not sure it changes our desire to have clinical quality metrics. I just was curious.
Yeah, I think employers, the private sector employers, are beginning to realize that these are important metrics, but seriously, where you're at with clinical quality is way more advanced than other clients that I have. Now, there's other areas that you don't have or you don't have PGs on, so it's a balance. But with clinical quality, you're leading the pack, is what I would say from my experience.
And I do want to note that sort of what we're proposing in this framework is really it's a tweak to the approach we've been taking to clinical quality all along. We're looking at incorporating some additional measures, and we're looking at providing some incentive in the scoring for carriers to exceed the 75th percentile, as well as differentiating the benchmark for straight PPO plans versus coordinated care model. So those are just some kind of, I would say, refinements that we're proposing to incorporate into what we have been doing historically.
Okay, so I have questions about 3 out of these 7 measures you're proposing.
Okay.
Rating their health plan is subjective, or do you have a way of measuring that's more objective? How well doctors communicate is also a subjective measure. And getting needed care, what's the criteria for determining what that is? The others all are pretty black and white.
Yeah, so those 3, Jeff, are all survey measures from the health plan CAP survey, which is a survey plans do of their commercial populations that, and it has a standardized questionnaire that asks these questions. And so it is, I mean, it is member self-report. It's a survey. But it does, at the same time, it's, I mean, you know, it is an NCQA validated standardized survey. And it does have national percentiles that you can benchmark against for how for responses on those questions.
Jeff, those are meaningful. You know, my comments were going to be on those 3 questions also. At least my understanding is that, and it was in the past, it is a random survey to commercial members. It is not, you don't get results for a particular group. So
Right.
you're not collecting data just on OEB members. You're not collecting data on PEB members. It is a aggregate of all of the commercial members. There's also one for Medicare and I believe for Medicaid. But I would say, you know, having been involved, being an operations medical director, we think that back in the days, we think that the ones that are listed there are, particularly the last 2, how well doctors communicate and getting needed care, are critical for looking at the service or the patient experience. Ranking their health plan, I'm not sure how helpful. That's not very directional, but around doctors' communication and getting needed care, that access piece, those 2 are very important. I would drop the rating your health plan.
Okay.
Well, this is Michael. The only thing I would say is that is a measure of how your contractor is, if you would, the health plan partner, the organization. So this is looking not only about the experience with the healthcare system, but also how your direct contractor is functioning vis-a-vis your membership. That's what it's measuring.
Yeah, but it's not your membership. It's the total commercial population. Unless they've changed caps.
No, it is generally commercial book of business.
Right.
Part of what you run into with the survey measures in particular is that in order for a carrier to do PEB or OEB specific rates, they would have to have a significant enrollment of PEB and OEB members, a significant, you know, critical mass of the population, and they would have to separately sample those members to do their own survey, and that, you know, that runs into additional cost above and beyond simply doing a commercial book of business survey. So again, it's balancing administrative burden, I think, on some of these where we would, you know, perhaps look to a commercial book rate rather than a PEB or OEB specific. Are there other questions about this slide or other comments at this point in time?
Should have asked you this earlier, but why are not Kaiser and Moda broken out under OEB?
Well, you know, I guess that would probably just be due to oversight. I think, you know, the measures are generally consistent across carriers. So I mean, I think, you know, the flip side of that is I think where it says Providence, Moda, Kaiser for PEB, we could have compressed all 3 of those into a single column that said PEB because the measures are the same for those carriers.
I'm not sure they are with OEB, but maybe they are.
OEB had a little bit of differentiation for PPO versus PCP 360, and we are moving in a direction of wanting to get aligned measures across all carriers and across all plan types within the carriers, especially for these HEDIS measures, which are, you know, standardized, nationally developed measures of clinical quality. So again, this is proposed for 2022. And I'll move on to the next slide if there are no other questions.
I'll just have one final comment. I think that the list that is outlined here are involve large numbers of patients and are recommended to pay attention. You know, these are important and really good measures. So, and they've been validated. They've been around for a long time, and OEB and PEB have been looking at them together, and so they're good. They're good measures.
Okay, account management, PGs. This is really looking at the performance of your account management team as opposed to the administrative and operational measures, which were more claims administration and customer service or clinical quality. And so there are some fees at risk with those other state employee benefit plans. You can go to the next slide. So there are a couple of metrics you have for account management for both PEB and OEB. We've carved those out into a separate category just to distinguish them between the administrative and operational. And then we're suggesting some additional metrics that, again, Ruby and I both agreed on, we commonly see in other contracts. So this is around report submission timeliness, accuracy, responsiveness, and then overpaid dollars recovered and reporting on that. So these are some recommendations we have for increasing this area and actually calling out by itself for account management satisfaction. The details of this we would need to work out in terms of with the carriers and with you, of course, of how those are specifically measured. Any questions? Okay, I guess we can go to the next one. Clinical management. So these, I think I was referencing before, it gets a little confusing. These are around the performance of the clinical management teams, if you would, at your carriers and administrators in terms of the functions that they are performing for you. So this would be things like utilization management, which is like prior authorization, case management with complex or catastrophic cases, disease management for people with chronic diseases, and so forth. And I acknowledge that this is a new area. So we're only, I mean, I could come up with a whole bunch of them. I used to work for a freestanding care management firm, and we would have, you know, a dozen of these. I'm just suggesting these. The reason I am suggesting these is because you want to know satisfaction with the program, with the interaction with the clinicians at the carrier, the administrator, the overall population that you're managing, how many of your high-cost claimants are being managed by your carrier or your administrator, and then timeliness of the utilization management decisions, which does impact access to care for your membership. So a couple of these are related to member experience, a couple are related to overall population health management, and then the other is related to how well they're performing in managing the high-cost claimants, which is related to your fiduciary guiding principle. So there's others that we could look at later, but I thought, because this is a whole new category, starting with these might be the best ones to get started with, and then we could look at others down the road potentially.
This is Tom. I have a quick question about clinical case management, whether or not it's done by the health plan or whether or not it's been integrated into the delivery system. So let me take for an example and how you count those. So if you more and more of the larger medical groups are developing pretty sophisticated clinical management systems within the delivery system. And in that situation, there's not much reason to have the health plan do something in addition to that. So I agree that this is one of the game changers. This is how we start getting at value-based care. And so we just need to be able to have a way for these are whether or not the management is at the delivery system or at the health plan level, both need to be included to make these make this worthwhile.
Yeah, this is Michael. I totally agree with you. This is a dialogue we would want with your health plan partners to find out, are those large health systems able to report on this? But that's a really good point. The other point on this one is, how is engagement defined? And I've been in hours of meetings about how to define engagement. The way I would define it is a patient, a high-cost claimant, which would have to be defined, that's had an assessment and has a care plan in place, and potentially one follow-up live interaction with the patient. So that's the level of detail that would need to be worked out about, does it account for the plan and for major health systems, and do the health systems, can they even report on that? And then the other piece is, how do you define engagement and how do you define high cost? So all those things would have to be detailed. But
yeah, I agree.
Point well taken. Yeah, that would be the ideal. I just don't know where the health systems are, have the capabilities of doing that. My experience with health plan administrators and carriers is they should be able to report on that.
Otherwise, we're duplication is
right. That's right.
Is not something that we want. And I have a personal philosophy that having the case management closer to the delivery system as compared to the health plan is better. But that's a belief that's hasn't been proven.
Oh, no, it's been proven. No, you're absolutely right. There's research that shows that that's absolutely the case. Absolutely.
Okay, good.
Yep.
Good
I
to know.
Totally on board with you. For me, it's just a matter of, can the health systems report on that with whatever care or case management.
Well, they're going to have to figure it out if we're
that's right.
If we're going to have this metric.
Yep, that's right. So anyway, I just want to make sure you knew that's the rationale for what I have here. I mean, I could have had like number of nurse line calls, disposition of the nurse line calls. I mean, on and on. But I thought, okay, let's just really stick with what appeared to be the most important. So see you later. You can go to the next slide, I think. And James, I think this is you and maybe Emery on the transparency.
Yeah, transparency is a new area. It is inspired by some of the work we did on site neutral and other sort of policy related things that it harkens back to earlier IWG work. So we came up with 4 domains: level of payment, how much do you pay? Change in payment, how much is it going up and down? Variation and equity in payment, is it pretty consistent or is it highly variable? Is there a high variation? So that is like the site neutral discussions we've had. And then one that's a little bit more qualitative on the methods of payment, but trying to get sort of a hybrid between an understanding of what % of the contracts that our plans have with provider groups have some language on VBP. When they do, what % of the payments are subject to the VBP? And when they're subject to the VBP, what % of payments actually are moving up and down, sort of a total dollar shifting based on VBP? And then a little bit of a qualitative description of what's under the hood, just so that we can start to know when we say VBP, whether we mean shared savings or episode payment or withholds or whatever. So the idea is that we would, within each of these domains, come up with some report-only, transparent things that would help us to benchmark, baseline, and analyze the variation in our program, and might serve to be more performance guarantees with tooth behind them later. Under level of payment, we're suggesting, as we've been doing for some time, that the major category of service, we could reflect actual provider payments as a % of Medicare, just so that there's a common decoder ring, a translator that we will know the relativities of the level of payment. All the plans, by the way, were very helpful during our early IWG work when we asked for current payments as a percent of Medicare. We were very impressed with how quickly those statistics were returned to us. Prescription drug is a little harder, and so we might need to talk with the plans a little bit, but some type of a benchmark on a prescription drug that would be sort of a comparable thing to percent of Medicare, except Medicare doesn't have published prescription drug fees. So NADAC is one that's used in Medicaid. We threw it out for, start the conversation. On the change in payments for the same categories of care, we would simply want the plans to report on how much the contracts went up or down year to year. For the variation and equity, think back to our site neutral project work. We would come up with a moderate set of service codes, and we would want to know what levels of payment and what the ratio or range of payments for that service are. A lot of this has been focused on hospital billing pathways getting much higher payment than office pathways. So again, the real details of the list of codes and how it would work and whether it would or wouldn't work for Kaiser, there's some work to do here, but as a conceptual framework, we would want to see whether we have widely divergent payments for the same thing, or for the same thing, are we paying about the same amount? And I guess I already kind of went through the bottom right-hand box on the standardized survey based on the land format. So this one is conceptual a bit more than what Michael presented. It does not have benchmarks pre-identified, and it would not be proposed at this time for any financial guarantee penalties. Because it's new, I'm guessing there might be comments or questions on this.
Well, I think that these are pretty exciting ideas. I really appreciate the work that's gone into it. As you were describing them, this felt pretty close to the mark, what I was thinking. And I also appreciate you sharing how our plans, the carriers were, cooperative and good partners. I appreciate that, and I appreciate that from them. So yeah, I don't know. It feels this feels like the right path. It also makes total sense that we wouldn't have real dollars tied to it, right? At first, just we're trying to figure out how it works, and what we're dealing with. That makes sense to me. It still feels important to pursue. So I appreciate it. And yeah, the further discussion about that, the prescription detail feels like a good conversation too. But yeah, really appreciate it.
Thanks, Sean.
This is Tom. My only concern is going to be while you're able to get health plans to help early on, that was probably with the idea that that data was not going to be publicized. So it's the public reporting piece that I think is absolutely important. I'm not trying to say it's not. It's just that it will be a challenge, I think, as health plans look at kind of lifting up the hood and showing what's actually in the underneath the hood.
Yeah, it was both impressive how fast it came out, and it was impressive to us that there wasn't the sensitivity that you are worried about at that time. And it was the innovation work group, and we're all working together to try and innovate. But it was really quite successful. We both monitored the hospital 200% bill, and we got the percent of Medicare and some other sort of broad service categories. And it really helped the innovation work group to see how things lined up. And I don't know for sure whether to be optimistic or pessimistic, but I do think that as a big purchaser, it's nice to know what is under the hood. We can't expose contractual details, but percent of Medicare is unlikely to be violating that. And then on the VBP part, you know, it's one thing to say, yeah, 30%, and it's another to know, well, what's in the 30%? And, you know, for example, if you have all your contracts with some language about VBP where you have very low standards and all the payments are subject to it, but none of the payments actually are impacted, it would be good to know. So I kind of feel like the what's in the 30% is an important thing for responsible purchasers to try and understand.
This is JJ. I have a question about transparency in general. So as a public employer, we obviously are in favor of transparency. One of the nice things about this group, however, is our ability potentially to coordinate with the legislature. I think this is a topic that we might reach out to our non-voting members to see if they can advocate for industry-wide transparency requirements through statute.
Yeah,
I mean, we just did pass a bill requiring some level of transparency, but not to this level.
Right.
But I think the legislature would be very interested in an idea that mandates all insurance providers publish what they're doing in order to hold them accountable.
Yeah, I'm not going to touch that one at this time, but thank you, JJ.
Yeah, Glenn Bailey, JJ, is going to be on shortly, and he's been around for quite a long time and seen every bill, so he probably might have some historical perspective whether there's been anything proposed like that.
Yeah, Glenn's on the call, so Glenn, unmute.
So JJ, I'm sorry, can you just repeat your question again?
Yeah, so we're talking about transparency and requiring our insurance providers to basically open things up so we can see what's actually happening. I think this is a great topic to advocate that the legislature require all insurance to do that, because it frankly puts public sector providers at a strategic disadvantage if they have to be transparent and the other non-public providers do not. I think the general populace would like to see what's going on. What's generating the rates?
Well, you know, in regards to transparency, I haven't seen really, you know, anything like that, you know, in regards to insurance. Of course, not all group plans, but the individual market and the small group market their rates are reviewed by DCBS, and there is a process for that. So, but yeah, I don't remember seeing anything about just kind of opening up insurance, and I don't know all kind of the legal ramifications around that, since they're not considered public entities in a sense, or underneath the law. They would be private organizations.
Well, yeah, they just did pass a bill that required not this level of transparency, but required hospitals to let people know what they're going to be charged, basically. So this is, to me, it's just another step along that path. And part of the innovation work group is to coordinate with our legislative partners. So I think this is a topic that I think that we should advocate to our legislative partners that they should take this up and consider it.
Yeah. I think there's a fair amount of overlap, if you really think about it, between these kinds of ideas, the Senate Bill 889 cost ideas, and even the all all claims database.
Mhm.
So I do think that we're trying to have a relatively simple linear list of things, but probably there could be some good work done to coordinate, consolidate, make sure that we're not requiring the plans to do 4 things that are almost identically the same for different purposes. But this was our thought about just trying to get to some pretty simple things that could allow us to understand what it is and how it's changing.
Yeah, JJ, Rep Nos, who's actually technically on this work group, he's actually had at least a few pharmaceutical transparency bills, and actually moved him quite a ways. But he definitely would be the one to pursue, and so we'll talk to him.
Okay.
Yeah, yeah. Thanks for saying that, JJ. I think it's a great point.
Yep.
And I think to James' point, we one of our members of the PEB board has been participating on the 889 group. Well, yeah. And then to your point, Ali, have you? Is there a chance to check in with Representative Nos, just about connecting with this work group again?
Yeah, absolutely. I check with him about every month to 2 months.
Oh, okay.
Year.
Okay.
Mm-hmm.
Just checking.
Yep, happy to.
So should we go to the next slide, which
Yeah,
is kind of a
probably
summary?
move on.
Yeah. So this is a summary of our recommendations. So we're recommending that the administrative and operational metrics and the clinical quality metrics have 5% of fees at risk each, depending on what we finally land on in terms of the specific metrics. And then the financial trend have 5% of fees at risk. So that would be a total of 15% of administrative fees at risk based on those 3 categories. The other 3 categories, the clinical management, account management, and transparency, would be report-only categories of metrics. And as we were talking, I just wanted to point out that the categories of PGs that probably are the most innovative or will be new to your plans are the financial trend metric and the transparency. The others should be pretty familiar, even though, for example, for PEB, there have been limited administrative and operational metrics and no clinical management metrics and a couple of account management. But the financial trend and the transparency are both pretty new, and particularly the transparency one that James and maybe Emery contributed to creating. So that's our recommendation. So a total of 15% of fees at risk, 5% of fees at risk for the administrative and operational measures, 5% for clinical quality, and 5% for financial trends. And then the others would be report only. And the next steps, as you can see, would be to get feedback from the carriers and the administrators, provide more specifications on the metrics, and then come back to this group to get sign off, and then ultimately back to the boards. And the idea here is that PEB and OEB both would have the same metrics in all the categories and the same fees at risk for the 3 categories, the administrative, operational, the clinical quality, and the financial trend. So that is our summary recommendation that between OHA staff and Mercer have developed.
And it sounds like you ended up under clinical quality. It wasn't just fees at risk. There was a potential upside. Is that correct? At least Margaret talked about that.
Oh, Margaret, do you want to respond to that one?
Sorry, I was just having a little mic trouble there. Yeah, the issue is not per se that there's an upside. It's more that the way we anticipate structuring the scoring is that carriers would need to achieve a certain point total in order to retain 100% of the fees at risk. and they would have the opportunity to reach to accrue additional points if they met a stretch goal.
Okay.
And that stretch goal would be something above the 75th percentile.
Yeah. So if you did well in one particular area, it would be okay to not do so well in another and not have fees at risk. I get it.
Yeah, I mean, you basically would have the opportunity to.
No, I get it.
Yeah.
Yeah.
Okay.
I understand.
Great.
Thank you.
So yeah, and this is, again, just to reiterate, this is all about current administrative fees at risk. So it does not incorporate any additional incentive dollars beyond current fees.
For what it's worth, I like the recommendation. Yeah, I mean, those sound like the right next steps and the right proportion.
One additional point I would like to note on the next steps, just to call it out, the very last bullet point under additional items notes that PEB and OEB will conduct annual reviews to evaluate categories and performance guarantees. And to give a little more detail there, what we're proposing is that the innovation work group would actually serve as the governance committee for performance guarantees in the PEB and OEB programs, so that as we move ahead into the future, this group would be kind of where this work resides, and that PEB and OEB would work in an aligned manner to examine guarantees every year, to keep guarantees current, to update them as appropriate, and that governance of that would reside within this committee.
This is Tom. I'm fine with that recommendation. The key, if the group wants to move in a different direction, one, at least for the clinical metrics, Sean and I, as your representatives for PEB and OEB at the Health Plan Quality Metrics Committee, we need to know about that ahead of time. So again, if there's going to be if there's significant changes, new metrics that the group wants, the boards want to include, it does need to get approval through that committee, and there's a process. You know well, Margaret, because you staffed the committee for a couple of years, so we'll just need to keep that in mind.
Absolutely, yeah. To the degree that we potentially in the future identify measures that we'd like to use, we will need to do that in accordance with a timeline that allows us to take that request to the HPQMC.
Yeah.
Sean, you want to weigh in?
Yeah, that's exactly right. I mean, on the clinical measures in particular, if we need a different set or we need to add something, we need to know. That committee, the Health Plan Quality Metrics Committee, the way I would describe it is thorough. Their discussions of these measures, they don't just like throw them on there. So it is quite a process. So definitely need that would be a multi-year process of changing the set of the clinical measures. They're agnostic on these other measures, the financial and transparency and whatever. But when it comes to clinical stuff, yeah, it's a process to change it. Which we're happy, Tom and I are happy to represent. We just, need to know what direction we're heading in, and we'll try to move that way.
Okay.
I have one more comment. These measures don't include discussion around health equity and disparities. And I know that Ali is getting a group together to spend more time looking at implications for OEB and PEB. We need to have a space holder in this dialogue for something like that. An example would be, are we measuring how well people who have English as not their primary language are getting appropriate translation services when they're receiving care, as an example. So we need a placeholder for that.
Yeah, Tom, this is Michael Garrett. Yeah, I'm doing a lot of work in the health equity space, and it's near and dear to my heart. So thank you for bringing that up. There are many issues related to this. For example, getting race and ethnicity data into a data warehouse to produce reports to show. That's just an example of being on the demographics of gender and age. And so I think we want to be a little careful about putting them in the bucket of PGs as opposed to putting them in the bucket of health equity reporting. But ultimately, I like the direction you're suggesting, which is, I think in a couple of years, we would want to see progress. Once we come up with the human metric related to health equity, then we want to see improvement with XYZ subpopulation, right? With preventive screenings, chronic care guidelines, avoidable emergency department use, et cetera, et cetera. And we're also waiting to hear, there is some focus, I believe, with the Health Equity Committee potentially on developing metrics related to health equity, controversial topics. So absolutely, it's on the radar screen. I just think it's a bit early to incorporate it into a PG framework, but thank you for the reminder.
Okay.
Yep. So is the sense from the IWG that this framework is okay to move forth with the action items then? With the recommendations and the additional action items?
Are we?
I think so. I think it's a good plan. The next steps make sense to me, and yeah, I like the direction it's going.
JJ?
I agree.
Okay. Then I guess the answer is yes.
Great.
I didn't leave anybody out, right?
I don't think Dana was able to join.
Okay.
Great. Thanks, Jeff. Thanks, everybody.
All right. Glenn, are you ready?
Yes.
Let's back up here.
I just wanted to give everybody a brief kind of legislative update so far. I will let you, the session has really kind of in the throes right now. We are coming up on a deadline. March 19th will be the next available deadline for folks to for bills to have their work sessions posted. Now they can still hold a public hearing, but by the 19th, they'll have to post that when the public hearing is going to be and when the work session is going to be. Sometimes they do it on the same day. On April 13th would be the next day, last day to hold the public hearing and work session in the first chamber. May 28th will be, well, last day to hold and come vote it out, unless it goes to Ways and Means, Rules, or Finance and Revenue. These are committees where a bill could live literally till the end of the session. May 28th will be the deadline to get it out of the second chamber, again, unless it goes to one of those exempt committees. June 27th is constitutional sine die. Their target, I know, is June 21st, but we'll see if they make that target or go to constitutional. In regards to legislation itself, we really, for PEB and OEB, have a handful kind of a priority bills, ones that directly affect us, impact the organization or its policies. We have two bills that are going to require that part-time faculty at colleges and universities can participate in OEB and PEB with 90% paid by the state. Right now, they can participate if they are, if they self-pay. Senate Bill 12 is a bill that requires PEB and OEB health plans to cover certain costs related to travel to Mexico or Canada to fill and refill prescriptions. It's basically kind of what you would call a almost medical tourism program. And this really doesn't have much impact on our costs. It would only be about $500,000 a year with off of kind of a specialty drugs of 60 to 70 million a year. It also has a number of regulatory problems with it. It's kind of, I won't go into all the regulatory, but it relates to the FDA's determination of what people can purchase overseas in regards to drugs, tax-free status, as well as potential liability. But this does have a public hearing on the 17th. The next one is, well, this is actually kind of more of a drafting area, so I won't go into this. It would be where PEB and OEB, or PEB, excuse me, would need to set up collect data on unfunded pension liability, and based on money that's collected through the state, pay off some of that offset that's for school districts. This doesn't have a public hearing. 2810 is where we've actually put a lot of effort into and a lot of work. Rep. Dexter in the Healthcare Committee is seeking to create or require that PEB and OEB offer more Kaiser-like plans, or really kind of integrated plans with a number of different requirements about them. This doesn't have a public hearing as of yet. 3044 and 3094, these were bills that would require our health plans to sign the 889 VBP compact. They don't have public hearings, but it's almost a moot point because I believe most of our plans have signed on to that. 2010 was recently introduced. It would create a public option on the exchange, and it would require that OEB and PEB plans offer a public option, and would require that providers who treat OEB and PEB plan participants participate in this plan. We have provided some comment on this, and it does have a public hearing on 2010. This has some of the same problems that 3044 and 94 might have had, which could require us to go out for an RFP if one of our plans left and we couldn't fill the gap. And then also could have patient disruption implications if too many providers would leave. And then lastly, 845 just adds a member to the Public Employees Benefit Board, or that would have experience in administering health benefit plans. And then, lastly, just 2317 on the OEB side would require that we have two plans or two members that are non-voting legislative members.
Is that all that bill contains?
Yep.
So on the prior page, 2010. Could you elaborate on that one, please?
Sure. 2010 was sponsored by Rep. Salinas. The idea, of course, is to add a plan or plans onto the exchange that are as affordable as possible. And they have some requirements to meet that affordability, like you can only pay 100% of Medicare to the providers. It also calls on OHA and, well, actually DCBS to really seek if they can get a waiver from our initial waiver that the state got to do its innovation funds or innovation plans, excuse me, and to see so if the federal government can pay for it or provide some funds to it. But it's two parts related to PEB and OEB, or as I mentioned, is that our plans would have to offer if they were to be contracted with PEB and OEB, and then the providers would have to, as I said, have to participate in it. It's got a lot of questions to it, and there's a public hearing later today on that bill. You know, I don't know kind of how much staying power it has, but we'll see on that. Is there some specific questions you had in regards to the bill?
Well, I was just trying to see what the downside was to PEB and OEB, and I suppose it's only a slight possibility that we could have a carrier that serves our two boards say, you know, we're just not going to do this. So therefore, we're not going to insure you.
Well, yeah, I mean, that I can't say, you know, whether our health plans would say no, and but it does have that potential. And then the other thing too is if it required, if we got notice and we couldn't keep contracting with one, we would be required to go through an RFP, which can take up to 18 months to, you know, 2 years to both do and implement. And in the meantime, you know, it doesn't say anything in the bill about transition.
And does it mandate any providers to actually cooperate with that plan, one of those plans?
Oh, it mandates that those providers who are treating PEB or you know, PEB and OEB members would have to participate in a public option plan. They could not refuse to participate in a public option plan. I mean, bottom line, what they're trying to do is kind of use this as kind of a almost quasi leverage on the health plans and providers so that they get plans that are robust enough, I guess, and then with enough network.
So we could get some providers that would say, well, we were going to do Moda 360, but now we're not.
I don't know all the contracting with our plans, but yeah.
And we outlined, Jeff, all those risks that you just outlined in the analysis. So, and try to attribute the fiscal impact of that.
Yeah. Interesting.
Yeah. Lynn and I actually met with program reps on that bill, their sponsors, last week, and talked through some of that.
Okay. All right. Thank you, Glenn. I think we're ready for a short break, and then we'll come back and get updates on Lodestar and Centers of Excellence. So it is 2:56, about 3:05. Okay, let's begin. We got everybody? Here comes time. Okay.
All right.
Updates.
And I think James is first up.
Yeah, and mine can be pretty quick. Margaret, if people want to, well, we'll start out and then we'll see if people want to like get a little taste of the links. I'm not sure if they would work for you or if I would need to do them. But I'm prepared to share if needed. This is intended to be a quick update. The RFI is been drafted and finalized, and it is just gone out. So the RFI went live yesterday, 7 a.m. West Coast, 10 a.m. East Coast. They're about 40 questions each for the sort of hard side of network payment data quality vendor side, and another 40 questions or so for the advocacy side of the house. We used an online proposal approach with Proposal Tech. And so the vendors, of which we had quite a few, got invited to view that link and see the RFI and respond online, which will make the evaluation process easier. And then the RFI was linked to the other thing I've shown the group a few times, the sort of conceptual framework design space that is at the other link. We're planning for the responses to be due at toward the end of April, April 19th. And next slide. Again, about 40 plus vendors. We tried to look for names we knew and didn't know. And so part of our process was to source and come up with some good ideas for people who might want to think real hard and help us achieve our vision or improve it. There's a bit of a focus on high tech for the payment technology side and on high touch for the advocacy side. We were looking for people to not sell us their product and tell us what they have ready already, unless it actually fits perfectly. But we wanted them to think real hard and have creative approaches to integrated solutions. For example, we included Amazon's new pharmacy practice and a company called RX Savings Solutions, which, as I understand it, can look at your insurance copays and compare them to the GoodRx or Select Care and kind of come up with the best price for your pharmacy medications, regardless of insurance. However, we also, in our RFI, asked for someone to just cut through the fog on pharmacy and come up with a solution with or without a PBM, where they're kind of like the medical side, there'd be a broad list of drugs at a good price with transparency and consistency. And we had less of a prototype on the pharmacy side, but we suggested that some kind of a benchmark, baseline, open, transparent, less being held hostage as a member who needs a drug and more being served. I don't think I have a third slide, so there's a short update unless someone wants to see either the RFI format or the design space again. Or any other questions?
I think James, you should read the RFI to us, live.
I would love to do that.
Please don't. I'm just kidding.
I will say that, it was fun to work on this. This is what the spirit of the innovation work group should be. And we put our hearts into making this thing, and we put our hearts into sending it out. We've had some questions from some vendors, so we're getting some attention, a little bit of confusion and some attention. So we're trying to resolve the confusion and keep the attention. There is a risk that we don't get 50 brilliant responses, but I sure hope we do. So now it's the wait and see if anybody comes to our party.
You mentioned the possibility of seeing the RFI.
Yeah, I could do a quick just overview demo of that. Can I get the sharing, Margaret?
Yeah, I have stopped sharing, so
Okay,
you
here
should be
goes.
able to use the share content icon.
Yep. I think if I share my screen. So this is the basic proposal tech format, and it's one of those expandable. Can you guys see it?
Yes.
Okay. It's one of those expandable deals. There's a little introduction, and my internet now needs to load. You know, some background, logistics. I will point out that on several of these tabs, we do have the link so that we really want them to go read the conceptual framework on that other site that we've been working on. So they're sort of meant to be a match set. Then on the network payment data quality side, we are investigating things like a broad network, this Medicare related fee schedules, and the ability to quickly and accurately update those and have them not be exactly Medicare, but percent of Medicare. Some discussion about how the interface with the softer advocacy side with the high tech, high quality administrative side would work for things like utilization management, data warehouse, quality metrics, kind of basics like provider directories, which need to be more interoperable between the advocate, the member, as you know, like we don't want the same old provider directory. We want them to be able to do different analytics like episode level analytics. And you can see some of the others. We're going to want them to be able to do this percent of Medicare plus other alternative payment methods. So, you know, as the quality related payment phases in, it might be that there's some prepaid, maybe there's some primary care prepaid, maybe there's some episode bonus. You know, we want them to be able to do the basics and the frosting. We had some pretty good discussions in the team about interoperability, like if this is going to be really transformational for the member, their app would need to be able to link with the different medical providers that they use, and maybe they would even have the ability to schedule appointments, and they can check all their labs, and everybody gets to see everything. And again, prescription drugs would be one where we would want it a little bit more integrated, that the doctor knew when he was prescribing whether it was going to be the wrong stupid prescription or the right cheap efficient prescription given the plan design. So there's a focus on that. The advocacy questionnaire. You've seen some of these slides more often. This should look familiar. We want that advocacy approach to be super front and center, high member engagement. We want that to be able to have the person do self-service with an app, computer, or whatever, and we want them to be able to get phone or full hand-holding if needed. We've got a section on health equity, social determinants of health, and then just some of the basics about needing to know and help people with their benefits and with their out-of-pockets. So that's the basic framework, and we are excited and nervous about what we'll get back. I have this up too. This is just the review. Like this has had a we continue to refine and improve this thing, but it's the one you've seen before with the new Lodestar release date. So if other people want to respond to the RFI, if someone is interested, they can go to Proposal Tech, even if we didn't invite them, and they can register, and this is a publicly available RFI.
Interesting.
That's a lot of work went into that. Well done.
Well, thank you. Thank you. Now I don't know how to unshare. Oh, there it is. No, there it is. Okay.
Thank you, James. And do we have an update on Centers of Excellence?
Yeah, so Centers of Excellence. In April, we will be going to both boards, specifically asking them for their agreement for the innovation work group to pursue development of a Centers of Excellence program for PEB and OEB. So that will be happening at the April 6th OEB meeting and at the April 20th PEB board meeting. And again, what we'll be going to the boards asking is, well, first off, a couple of things. We'll be providing a little bit of the background in terms of the work the innovation work group has done to date, and a little bit kind of an overview of some of the data that was looked at by the work group to essentially make the case in terms of the value of further development work on a COE program. There are a couple of areas where I think the work group has really articulated a desire to focus on Oregon providers to the extent possible and to work with current carriers on developing a COE program. Essentially, as the request, we'll be getting the board's agreement that this is the right direction for the work group. Based on what the boards indicate, we will then come back to the work group and develop a more specific timeline and project plan for full development of a COE program, including the critical decision points that need to be made, the timing for those, and what actual creation and launch of such a program would look like. So that'll all happen in terms of getting that board input and approval in April. And then pending what the boards indicate, we'll begin to work in May on what comes next.
Okay. When's our next meeting scheduled?
So we are scheduled to take a break in April, which means that our next meeting will be Tuesday, May 18th. For the May 18th meeting, we'll have several things on the agenda. One will be to regroup on Centers of Excellence and what comes next. The other will be to take a look at our finalized performance guarantee approach. And then the third item will be to get sort of a first review of what the Lodestar RFI responses look like. So it'll be pretty three pretty full topics, and I do anticipate, we'll be coordinating with the consultants, but I anticipate that the Lodestar RFI work will carry over into June as well, certainly.
Wow, lots of suspense. It's almost like Who Shot JR?
Right. Good stuff on the agenda.
Look forward to it. So before we close, from the committee, any last questions? Okay. Comments? Go ahead.
I was just going to note, we do want to check in and see if there's anyone other than the committee who wants to provide any public comment at today's meeting.
That was next. Okay.
I read your mind.
Thank you. This is Rose's chance to speak up, I guess.
Yep. And I'm not sure if Rose is dialed in, but I don't believe we had anyone signed up to provide public comment. So unless there is anyone, unless there's anyone present who would like to speak up, I don't think we have public comment today.
Doesn't look like it. Nobody's raised their hand over on this list, so.
Yeah.
Okay. Well, thank you. I think with that, we will adjourn the meeting.
Great. Thanks, everyone.
See y'all later.
Thank you. Thanks for all the work.
Bye.
Bye.